we'll do is then we'll transition into a presentation by Dr. Taylor, which we're really excited about. There's a new topic that we haven't covered before at Ivy Lab. And then we will end with a research in progress presentation too. So jam-packed Ivy Lab meeting, and we're excited to get things going. So Lilia, I'll hand it over to you.
Sounds good. Okay. Okay, let's go ahead and get started. So, lots of exciting updates from this month. So first, Dr. Martin was listed in Richmond Magazine's top docs list for 2023. Okay, and so Michelle won Best Poster in Clinical Research at VCU Women's Health Research Day. Michelle is one of our senior lab members. She's a third-year PhD candidate. I believe she's mentoring 5 of our students, and she at this conference was, I believe she was managing 4 posters and presenting 4 posters. So it's safe to say we are very grateful to have Michelle as part of our team. And so here's a group picture of the Ivy Lab at Women's Health Research Day. From left to right, there's Dr. Svikas, Michelle, Gus, Sajani, Shreya, and Dr. Martin. And not pictured is Brenna and Catherine, who couldn't physically be there, but they put in all the work and their research was presented at Women's Health Research Day. And then also this last month, Ivy Lab went to American Society of Addiction Medicine conference. So here are some action shots of our lab members. So on the left is Sajani, in the middle is Phoebe, and on the right is Gus. And then on this slide, here are each of the lab members with Dr. Martin in their posters. And then on this slide, this is some pictures from Dr. Martin's symposium, and on the left is Dr. Martin with her panel. Okay, now let's get into the research updates. So we currently have 3 manuscripts in review. 2 of them are Annabeth's, and 1 of them is Dr. Martin's. And then this month, super exciting, Andrea Nguyen got her manuscript accepted to Psychiatry and Frontiers. And if you haven't already, we do have a Twitter channel, and you can give us a follow and keep up with our conferences, any publications we have, and we also have a YouTube channel where we post all of our talks. So if you ever miss a talk, you want to catch up, or you just want to learn more, you can give us a follow or check us out. And now going into the study updates. So first off, we're starting with Project Better, which provides a theoretically grounded assessment of feasibility and acceptability of a technology delivered educational intervention for pregnant and parenting people receiving medication for opioid use disorder. And this is a randomized clinical trial that is ongoing in the recruitment phase. And there are currently 26 participants. And the graduate research assistant is Annabeth. And next, since we were just talking about Michelle, is Project SOAR. And Michelle is the graduate research assistant for this. And this study investigates the relationship between sleep and opioid use disorder recovery. And there are currently 160 participants recruited, and it is ongoing. And next, we have the registry, which is an ongoing record to track clinical outcomes of our pregnant and parent and postpartum parents who seek addiction treatment with OB Motivate Clinic. And Annabeth is the graduate research assistant for this position. And there are currently 132 participants enrolled, and it is ongoing. And next, we have the postpartum recovery study, which compares biopsychosocial factors such as pain, mood, impulsivity, and maternal infant attachment. And is captured during the 3rd trimester of pregnancy and within 6 weeks postpartum between women with opioid use disorder and women without substance use disorder. And so recruitment is finished for this, and all of the follow-up visits have been completed, and now just the chart reviews are ongoing. And the graduate research assistant is Annabeth. And our next lab meeting is to be determined. So if you are interested in presenting, please reach out, and please reach out and you can email me, and we would love to have you.
Great, thank you, Lilia. Those are all great, exciting updates as usual. We appreciate it, you getting all that together. Like always, feel free to reach out to Lilia or me with any questions about anything exciting happening in the lab. So we're just going to keep on moving along, and now I'm going to hand things over to Dr. DaShaunda Taylor. DaShaunda is an assistant professor of epidemiology at ODU, so in Norfolk, Virginia, and I had the pleasure of working with her when she was here at VCU before she transitioned over to faculty life in Hampton Roads. And she's going to be speaking to us about a different type of research methodology, taking existing evidence and synthesizing it in order to have more impact in the scientific literature and also for clinical care. So I'm going to hand it over to you, Shonda. Thank you again for speaking.
Thank you for the nice introduction. I'm going to make sure I share my sound when I do this because I have a little portion that I want to show a video of. All right. So I'm excited to present to you all today or this evening on systematic review. So as Dr. Martin just mentioned, I am an assistant professor at Old Dominion University, but I did do my doctoral training at VCU, and I also worked at VCU for a couple of years as a lab and research specialist in obstetrics, looking at genetic and molecular biology components of conditions such as preeclampsia. So let's get started on looking at systematic reviews. So today we're going to look at what a systematic review is, some guidelines for systematic reviews, registering systematic reviews, some software that you can use to help conduct systematic reviews, and also briefly look at 2 publications that I was a part of when I was a doctoral student that focused on co-occurring substance use. So during my doctoral training, there was a group of doctoral students and master's level students, as well as 2 faculty advisors that completed systematic review. We were able to get at least 2 publications out of that. So I'll talk about that experience, and I'll wrap up with lessons learned and tips. All right, so what is a systematic review? So if you were here, I think it was 1 or 2 years, I think it was a couple of years ago that I gave the presentation to the Ivy Lab before about study design. This may look somewhat familiar. I've updated it, but basically it's showing the different types of studies. So there are descriptive studies, analytic studies, and then there are special types of studies. Systematic reviews are under that category of special studies. And systematic reviews often can include meta-analyses, and I'll get into what that means. But some of the other ones that you may be more familiar with are the randomized controlled trials and then cohort studies, as I see your team has been working on several of those. So systematic reviews are basically a review of a clearly formulated question that uses systematic and explicit methods to identify, select, and critically appraise relevant research. It also helps to collect and analyze data from studies that are included in the review. So here, you'll see that there are several components to systematic review. There's a planning phase, systematic literature searching, then there's the appraisal and synthesis of information, as well as reporting of findings. So this image came from Auckland University of Technology, and I like it because it goes through several of the phases. So for the planning phase of a systematic review, you're really searching for existing reviews and protocols that have already been developed. Then you would go on to formulating your review question, and once you identify that there's not been a study that's already done so, and developing a review protocol is also important. When you are conducting the actual review, you want to make sure you have a search strategy that's explicit, so includes all of the information as far as dates, which databases you'll be looking at, and the type of information, including inclusion and exclusion criteria that you'll be assessing. You want to do a systematic search of the databases and the grade literature and download those citations to a reference manager. So some of the reference managers I know are available at VCU are Mendeley, Enzotero, and I know there are probably a couple of others, but I can't think of the names right now. For appraisal and synthesis, you select the studies that will be included, you extract data, you synthesize that data, and then you report on your findings by writing up the review and hopefully get them published. All right, so I like this diagram here because it goes through some of the differences between a literature review and a systematic review. And so, you know, we all have to do literature reviews whenever we're preparing our manuscripts for publication. But a systematic review is much more in-depth endeavor. With a literature review, you're taking, for your definitions, you're taking qualitative assessment and summarization of the evidence on a topic, and it's usually informal. And you can look at subjective methods to collect and interpret studies. Whereas in a systematic review, it's really an overview of a primary research on a very focused question. So that can identify, select, and synthesize high quality research evidence relevant to a question. For literature reviews, the goal is really to provide that overall summary, whereas for systematic reviews, you have a focused clinical question. And also systematic reviews, one of the goals of it is to help reduce or eliminate bias when reporting on your findings. As far as the type of questions that are asked in a literature review compared to a systematic review, a literature review can be a general topic or a specific question you can really choose, whereas with a systematic review, you have to have a clearly defined and answerable clinical question. This chart here says that they recommend using the PICO format as a guide, and PICO is a format that's been developed to help with formulating research questions. It's commonly used in evidence-based clinical practice, and this format creates a well-built question that identifies a few concepts. So it stands for like either patient or population problem, the intervention, and then your comparison, if there's any, and as well as the outcomes. Example of that would be in adults with recurrent furunculosis, which are skin boils, do prophylactic antibiotics compared to no treatment reduce the recurrence rate. So in this case, for the PICO, the population or the patient would be adults with recurrent furunculosis. The excuse me, the intervention would be prophylactic antibiotics, and then the comparison would be individuals who receive no treatment, and then the outcome would be reduction in recurrence rate. So there are other formats that you can use to create questions, but that's one of the most common ones. There are other ones considered, especially for epidemiology. So those are PEO format. So that's population, exposure, and outcome. And then there's also the spider format, which was adapted from the PICO tool. So that's really for qualitative and mixed methods research. All right, so when you're looking at the different components of a literature review has your typical introduction, your methods, your discussion, your conclusion, and your reference list. Whereas the systematic review will have also include your eligibility criteria. That's one of the most important components. You also have to explicitly state your search strategy and include an assessment of the validity of the findings as well as your interpretation and presentation of results. And, most importantly is your reference list since you're looking at articles. For the literature review, you can have one or more authors, whereas for systematic reviews, you really want to have at least three to be as fair as possible, because you'll have to have inter-rater reliability, because there'll have to be at least two people who are going to look at and assess the studies. And then if there's disagreement between whether studies should be included in a review or not, then there's usually a third person to kind of break that tie. So that's why they say it's best to have at least three people. I think we had about 8 students, if I remember correctly. I think it was 7 or 8 of us when we were doing our systematic review. For your timeline, literature review can take weeks to months, whereas systematic reviews can take months to years. It is on average an 18-month endeavor, and I don't know if that includes going through the publication phase. So it's quite extensive, and you have to be dedicated to complete a systematic review. For literature reviews, the requirement is that you have an understanding of the topic and you perform searches of one or more databases, whereas a systematic review, you have to be really thorough when searching your databases. You have to have a thorough knowledge of the topic, as well as the relevant databases that the experts use for that topic. And then also, you may want to have a little bit of experience with statistical analysis resources, but that's more so for the meta-analyses. If you're not conducting a meta-analysis, then you do want to have basic statistical skills just for looking at the quality assessment and making sure you're calculating all of your inter-rater reliability steps correctly. But it is not as much of a requirement if you don't have if you're not including a meta-analysis. And then lastly, for the literature review, you're providing a summary of the literature on the topic, whereas the value for a systematic review, I think, is exponentially higher because it connects practicing clinicians, you all, to high quality evidence, and it supports evidence-based practice. So is really the gold standard. So you'll see here in this pyramid how case reports and case series are our base or our bottom layer of information. So they provide individual circumstances and cases. Above that, more evidence is cohort studies. And above that is randomized controlled trials, which a lot of time we consider the gold standard. But even above that are systematic reviews and meta-analyses. So that compiles all of that information from cohort studies, from randomized controlled trials, and even case reports and things of that nature in some cases. But they give a clear overview that's hopefully unbiased of the evidence. All right, so you kind of got a taste of this on the last slide, but I really like how these two figures show the relationship between reviews. So as we mentioned, literature review summarizes the topic. It's broad, it's qualitative. It may use some sources that are biased. It doesn't necessarily define the type of studies that will be included. It really looks at everything. Systematic reviews answer a specific question and they define a specific search strategy and include that inclusion and exclusion criteria that we mentioned, and can include that meta-analysis. Whereas a meta-analysis looks at studies from a systematic review. So they're always part of a systematic review, but they're not required to be a part of one. But if you've done a meta-analysis, a systematic review has come first. And it's important because statistical analyses from combining results of similar studies, pooling them to get a statistically relevant result, whether that's significant or not, is important because it may potentially overturn results of smaller clinical trials. And obviously having several sources of information that give us that overall view is much better than have one clinical trial or a piece of information that's not supported by other studies. So all systematic reviews are literature reviews, but not all literature reviews are systematic reviews. Same thing with meta-analysis. There are also other types of reviews, including integrative literature reviews, rapid reviews, scoping reviews, and then umbrella reviews, which are reviews of systematic reviews. That's really meta. But we're not going to discuss that here, but the VCU Library's website has guidelines and resources that provide more information on that. And I'll mention it later, but John Cyrus, who is the VCU research and education librarian, really helped us out. He was great, and he is a resource that you should definitely tap into if you're planning on undertaking a systematic review. All right, so where can you find systematic reviews? So two major sources are the Cochrane Library, which is a database that has over 5,000 reviews of research on medical treatments, practices, and diagnostic tests. The Cochrane reviews are considered the premier source for evidence-based practice. And then I'm sure everyone's familiar with PubMed as the other search engine that we use for citations of biomedical literature, and they include systematic reviews as well. And so here, this figure just shows the Cochrane search page, and it is pretty standard. It contains the 4 tabs that you're kind of used to seeing when searching. You have your search buttons, you can have filters, there's a search manager, you can include the medical terms under the mesh headings, and then you can just browse certain topics if you want to. All right, as far as guidelines for systematic reviews, there are many, 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 many guidelines for different types of studies. The most relevant for this presentation is going to be PRISMA, but some of the other ones that you may be familiar with for randomized trials is CONSORT, is Consolidated Standards of Reporting Trials. For observational studies, we use STROBE, which is the Strengthening the Reporting of Observational Studies in Epidemiology. And then for systematic reviews, it's PRISMA, or the Preferred Reporting Items for Systematic Reviews and Meta-Analyses. Some other ones that you may see are STARD, so Standards for Reporting Diagnostic Accuracy Studies, and that's really for diagnostic or prognostic studies. Case reports, they were really original with their names. They just took the first 2 letters of case and report, and they made the CARE guidelines. And then the clinical practice guidelines, appraisal of guidelines, research and evaluation, or AGREE, and reporting items for practice guidelines in healthcare, or WRITE clinical practice guidelines. All right, so the Equator Network is where you can find a lot more information on the different types of guidelines for conducting different studies, depending on the study design that you're interested in. For systematic reviews, PRISMA is the main one. There's also PRISMA P, which is for developing protocols for systematic reviews. And then there's also one called SPIRIT, which is a standard protocol items recommendations for interventional trials. So there are a number of reporting frameworks that ensure reproducibility. And like I said, those can be found on the Equator Network. I think they said there are over 500 guidelines available for use. And so we'll just talk about PRISMA really quickly. So PRISMA, the preferred reporting items for systematic reviews and meta-analysis. This is an evidence-based minimum set of items for reporting in systematic reviews and meta-analyses. So here you'll see a flow diagram for updated systematic reviews, which included searches of databases and registers. So for PRISMA, they originally came out with the checklist in 2009. They had an update in 2015, and then they also had another update in 2020. And so this is the type of flow chart you would generally see when you're reading publications on systematic reviews. I don't see this section as much. The previous studies section, you'll probably see that more in umbrella reviews. But for the identification of new studies via databases and registers, you want to include the number of records identified. So this can be all articles and information identified. And you want to include the database names and registers, and then any records that are removed because of being duplicates. Then you want to screen your records, and you want to make sure you discuss which records were excluded and why. Reports sought for retrieval. So same thing, you want to make sure that you assess the reports or articles for eligibility criteria that you have already written up, and then give your reasons for excluding each based on those eligibility criteria. And then you'll get down to the reports that are included in your review, and the total number of studies that you have found that were relevant to the topic that you're doing your systematic review on. All right, see, there is a question in the chat where you can get all the, oh, okay, thank you, Dr. Martin. And I'll also have at the end a slide of resources. And if anybody wants the PowerPoint slides, I'll be happy to forward them to you to share. All right, so here is page 1 of the PRISMA checklist. It is extensive. So they tell you from everything from your title to who you should acknowledge at the end, what you should do, what's appropriate. So for the systematic review, you want to make sure that your title of your systematic review when you're reporting for publication identifies the report as a systematic review. They have certain criteria for abstracts that you include, and that's a separate abstract checklist. They also have an expanded elaboration of the abstract criteria, as well as why they made the update for 2020. As far as your introduction, they want to make sure that you include your rationale and objectives. The methods portion is really important because that's where you discuss your eligibility criteria, information on your sources, your search strategy, which databases you used, all the data items that you include, and then also your study of the risk assessment and effect measures especially if you're going to conduct a meta-analysis. And then on the second page here, when you talk about your results, you want to make sure you review the study characteristics, reporting on those different forms of bias, results of the individual studies, and then for your discussion, make sure that you provide a general interpretation of the information. For other information, you can talk about registration and protocols. So I'll talk about that a little later. I think it's coming up in the next slide about registering your systematic review and having a protocol for that. So I mentioned the PRISMA P. So that is a guideline for if you're developing a protocol for a systematic review before conducting the systematic review, as well as thanking those who have provided financial and non-financial support for you, any competing interest in the availability of data, code, and other materials. All right, so if you want to register your systematic review, Prospero, or the International Perspective Register of Systematic Reviews, is an international database that prospectively registers systematic reviews, and they include reviews on health and social care, welfare, public health, education, crime, justice, and international development. And so Prospero is the key features from the review protocol are included in this. So it's recorded and maintained as a permanent record. And anytime there are changes, they will show when the changes occurred and when you identified it on their website. So it never deletes it. It only adds new information. So you can go back and see from the original submission. And so they aim to provide a comprehensive listing of systematic reviews registered at inception. And this really helps to avoid duplication of systematic reviews. So you don't want to start working on a systematic review if somebody is already, 9 months or a year into a systematic review on the same exact topic. You might just be wasting your time, a lot of time and effort. So before you even be like, oh, I found a topic that I want to do a systematic review on, make sure that somebody else is not already registered on Prospero for that same exact study type, because that would be wasted effort. So you want to make sure we avoid duplication, and registering your systematic review is helpful with doing that, as well as reducing the opportunity for reporting bias. So when you put your study or your planned study on Prospero, it enables comparison of what you put in your original protocol with what you actually did when you completed the review. So your planned analyses in the protocol versus what was actually published. So it helps with transparency. This database was developed and produced by the University of York, that's their Center for Reviews and Dissemination, and is funded by the National Institute for Health and Care Research in the United Kingdom. All right, so they will allow you to register systematic reviews, rapid reviews, and umbrella reviews, and that's for human and animal studies. And here we just have some snapshots of what the welcome page for Prospero looks like, and then where you can go to register a review. But first, you also want to make sure that you search their database to see what relevant reviews have already been are already in progress. All right, so give me 1 second. Some of the benefits of Prospero, as I briefly mentioned, is transparency. So it provides prospective, permanent record of systematic reviews. It also helps to reduce bias because it reveals differences between those planned and published methods and outcomes. It helped reduce that duplication that I mentioned by allowing you to use that searchable list of ongoing systematic reviews. And then it helps people to comply with the PRISMA guidelines. Like, that's not the only set of guidelines, but it is one that's commonly used. So it supplies a public record of the planned methods and also raises awareness of the review to other people. So as far as software for conducting systematic reviews, we used Microsoft Excel when we were conducting our review, and Mendeley as our reference citation manager. I don't know if this software that I'm about to show you was available at that time, but we didn't know about it. And it would have made our lives so much easier. So two of my colleagues who were on that are on the publications that I'll show you later, two of them have used this program that I'm going to show you, and they said it's a game changer. Like, they sing its praises. So it's highly recommended. I have not used it, but we did it the hard way with Excel. So, but my two colleagues who have done systematic reviews since we've had these publications highly recommend the use of this program called Covidence. So some people pronounce it Covidence, but I think that's just because we're familiar with COVID, and apparently it came out before the pandemic. So it was just an unfortunate name. So let me see if I can share this video.
Hi, and welcome to Confidence. Confidence is a web-based software that streamlines
Uh-oh. Were y'all able to hear it and see it?
Yes.
Okay.
literature and systematic reviews, saving you time and hopefully tears on your review. Our intuitive platform has been designed by researchers for researchers, and we are now proud to support over 200,000 researchers and over 200 leading organizations around the world. So no matter your experience level when it comes to systematic reviews, Confidence will easily help with the heavy lifting that comes with importing citations to, facilitating the screening of abstracts and full texts, populating risk of bias tables, extracting data, and exporting. Let's take a closer look inside. When you start a review, you will notice that the interface is intentionally designed to guide you through the review process. The first thing you will want to do is invite people to join your review. An email invitation will be sent to join your review, and the reviewer will be automatically added to it when they accept. With Confidence, you are able to collaborate with anyone around the world. They don't need to be affiliated with your organization or institute. To import references, simply click the Import button and upload a file using EndNote, XML, PubMed, or RIS text format. Duplicates are automatically identified, and you can see how many were removed and check them too. Title and abstract screening is as simple as clicking Yes, No, or Maybe. Whether you are on your desktop or on the move on your mobile, you can quickly screen from anywhere and create a filter, add highlights for quick referencing, or even inclusion and exclusion criteria. Choose to view an abstract or not. Add a note for yourself and your team. View the history of a reference. Get a summary of conflicts to manage and make final decisions faster. Once decisions are made, studies with a yes vote move to full text screening. Full text screening then works in a similar way. Choose to include or exclude. When you do exclude, you'll be prompted to select a reason, which will show in your Prisma flowchart. You can customize your reasons in your review settings. When you are ready to do extraction, create a template from scratch or use ours to start with and customize it as you need to. Save as you go or hit Publish. Then begin extraction. You can also customize a quality assessment template to suit your needs in much the same way. Once 2 reviewers have completed extraction, you will be guided to complete consensus. The consensus screen highlights the number of conflicts between the 2 reviewers. You can easily select what the final decision should be on each data point by selecting either of the reviewer's data or by entering your final decision. The number of conflicts will reduce as you make your final decisions. Any comments added by a reviewer will be shown to help you make your final decision. At any point during the review process, you can update your review settings, manage your team, control criteria and exclusion, and view and manage tags. When it's time to export, choose the format that is right for you. You can export your references at any stage in the process and in many formats available. We also provide an inter-rater reliability export for the screening stages, together with all the data extracted and quality assessments you have added for your studies. And that's it. To dive deeper into the features, take a look at our education page, Confidence Academy, where you can register to one of our free monthly 101 live webinars too.
Alrighty, I see that a couple of people have already used Confidence before, so kudos to you for knowing about it. Let's see if I can get back without issue. All right. Awesome. All right, so that's a tool that'll help you be more efficient and effective when completing your review, and hopefully tremendously reduce the amount of time that it takes you to complete it. All right, so I guess I'll pause here for a minute to see if anybody had any questions or any comments about anything that I just discussed. You can just unmute yourself if you would like. I'll give it a second. All right, if not, then I will move on to discussing the systematic reviews that we conducted on co-occurring substance use. All right, so in this first article here, titled The Assessment of Co-occurring Substance Use During Opiate Treatment Programs in the United States, we looked at the assessment of co-occurring substances. This is also known as polysubstance use in those programs. And we searched 4 databases to identify a total of 3,340 records that were related. And so we excluded 121 duplicates, so that left us with 3,219 articles for screening. So those were a lot of articles to go through. We then assessed this information by, so we looked at abstracts for screening those after title screening. We did abstract screening to see if it still seemed relevant to our topic and excluded those that were not. And then we did full text article assessment eligibility. So you can see here, there were a few reasons why we excluded full text articles. So some were on detox or withdrawal studies instead of looking at opiate treatment for opioid addiction. The objective was not applicable. There was no polysubstance outcome, so maybe they were just looking at the opioid use and not looking at whether there was co-occurring substance use. And then and that study was not restricted to opioid users. So that got it down to 85 final articles that were eligible and qualified and reviewed. We assess this information by the type of substances included in the measurement of co-occurring substance use. So if individuals were seeking treatment for opioid addiction, then we looked at information on whether there was co-occurring cocaine, alcohol, marijuana, benzodiazepines, amphetamines, and tobacco use. And a lot of studies don't include information, especially on tobacco and alcohol. But we did. And the type of, we also looked at the type of treatment that was received. So whether they received behavioral therapies, whether we received pharmacological therapies, or whether it was a combination of the two. And then we looked at the measurements utilized to assess the co-occurring substance use. So whether the opioid treatment programs asked for self-report from the patients, whether they completed a urinalysis panel, or whether they looked at diagnoses of co-occurring substance use using the DSM Diagnostic Standards Manual. So for my part in the study, I helped from the beginning. We had to come up with a strategy. So we had lots of meetings with our team surrounding that. This was in the fall of my first semester in my doctoral training. And so I was just hitting the ground, kind of running. By that December, we started this systematic review. We had talked about it and been in the kind of planning phase a little bit, but my involvement became really clear in December of 2018. And then we proceeded from there, and we had a goal of submitting our manuscripts by the end of March of 2019, which was very ambitious. So I screened the 614 abstracts along with one other rater. And we had to come to consensus on anything that we didn't agree on. And if necessary, we had a third person. So one of the first co-authors here would break any ties if needed. And then we performed data extraction for those 85 articles. So that included information on for my part, the title, the first author, publication year, study objective, study design, type of intervention, the study setting, co-occurring substances assessed, when the use of those co-occurring substances were assessed. So was it at baseline, some point during the study, or only at the end of the study, or was it a combination of those? We also looked at the sample size and the follow-up time in the study. So that was just one half of that analysis. The second half was looking at the study results and outcomes. And so two other members of the team focused on that list. And when we were starting the process, when we were beginning the process, what we did was we did 10 practice articles just to make sure that everybody was using the same definitions, had the same ideas, and to make sure that when it came to our inter-rater reliability, it wasn't just because of some misunderstanding of a term. So I thought that was really a really helpful process. Like I said, we had several meetings for updates along the way, and of course, everyone contributed to manuscript preparation and then editing as well. And then also for the study findings, we found that it was a lot of the studies included information, but there was great variety on the information provided, on the type of co-occurring substances that were assessed. There are lots of inconsistencies in comparison, and so that made it really hard. We weren't able to compare. So our recommendation was that we need a standard measure or consensus on research for co-occurring substance use or polysubstance use. We don't even have one name for it. It's also called poly drug use. There are several names for it. So we want to make sure that we come to consensus on what the measures are, and that way that'll help us to be able to properly compare studies in the future, as well as to inform best practice guidelines for actually addressing polysubstance use. All right, so in the second article, we reviewed the influence of co-occurring substance use on opiate treatment program effectiveness, and we did that according to the intervention type, so whether it was behavioral, pharmacological, or that combined therapy. So treatment outcomes were generally defined as opioid abstinence, so whether they refrained from using opioids, or treatment retention. So as you can see, the flow diagram here is similar to the first one, but for the outcome for the eligible articles, only 34 studies met all of the eligibility criteria compared to the 85 studies from the previous publication. We also described special populations that were included in the study. So that included pregnant women, individuals involved in the criminal justice system, people who inject drugs, individuals who are living with HIV or hepatitis C, and then individuals with insecure housing. We found that overall co-occurring substance use was associated with negative outcomes for treatment, and that was regardless of the treatment type. However, there was some variation based on the co-occurring substance as well as the treatment type. So we also had a couple of posters that we were able to develop and present. So these are two of the posters that I presented. One was on the examination of polysubstance use in pregnant women during opioid use disorder treatment, and there was not much out there on that. But I presented that at the American Public Health Association conference in 2019. And then I also presented on the changes in co-occurring substance use following opioid treatment at the American College of Epidemiology in that same year. All right, so for some lessons learned and tips, there were many. I had never participated in a systematic review before. And I had no idea the extent of the undertaking it would be. A systematic review, like I said earlier, takes on average 18 months to complete. And that you have to have a really dedicated team. Our team essentially completed 2 systematic reviews in about a 4-month period. So I immediately swore off ever participating in a systematic review again after that experience. I've calmed down a little bit in the years since. I'll consider working on another systematic review, but it was a little bit of a traumatic experience. But I learned a lot. As a lot about substance use as well as systematic reviews overall. It was also one of the most productive periods of my life. So I can't fault that. There, like I said, were many challenges, but some of the lessons learned were really helpful. So I'll go over tips in a minute, but before I talk about that, I was like, even though there were all of these challenges that we had as far as time constraints, it was very stressful. I did not get much sleep. It created a really cohesive team because it's like we were all kind of like suffering together. So it really made us, I feel like, stronger as doctoral students. And we're like much better able to assess the literature when we're for our own studies, when we're preparing our literature reviews for later studies. So I really appreciated that. And as you were able to see, there's also some benefits in the fact that we conducted these reviews. We had 2 published journal articles, and we had at least 4 presentations. So I presented at 2 national conferences, and then one of the first authors, Courtney Blandino, Dr. Blandino, she presented 2 posters at another national conference, Society for Epidemiologic Research, or SER, as well. And then according to Google Scholar, as of today, these articles have been cited 9 times, and that's in a 2.5-year period. And so I'm really kind of happy with that influence. That's a short amount of time to have 9 citations. So I'm proud of us for that. But for the tips, I know I'm winding down, but if you're going to do a systematic review, I suggest you get organized early and have a realistic and detailed timeline. Have a dedicated team because a systematic review requires a huge time commitment. Consult extensively with the research librarian. As I mentioned before, John Sayers was seriously very helpful. He's a great resource. And then use software to help you stay organized. So as I mentioned, we use Mendeley as one of our reference manager. Covidence would be a good one, but any software that updates in real time is going to be the most helpful. And so here I've included some resources from BCU libraries about the PRISMA guidelines, Prospero, and Covidence. And if anyone wants any other references or information on the resources that I mentioned on the presentation, I'll be happy to forward those as well. Here's my contact information if you want to discuss systematic reviews more. And you can also find me on LinkedIn. I'm sure I'm the only DaShaunda Taylor. If you see DaShaunda Hilliard out there, that's me as well. That was my maiden name. And so, are there any questions? I'll stop sharing now.
Thank you, DaShaunda. That was great. I did one systematic review many years ago, and we did not use that software. We did it on Excel, and that looked like a lot better experience potentially. So I love the idea of reviews, especially for trainees who maybe have a limited amount of time to do a research project, like residents, et cetera, who don't have time necessarily to do primary data collection, and maybe you're still learning some statistical skills, but you can do a systematic review of existing evidence. I think it's a really good skill to learn and to look into.
I totally agree.
What questions do people have for DaShaunda?
Thank you, Sajani. I think everybody's just ready to get out and go do a systematic review now.
Yeah, right. Well, if you think of any, feel free to put them in the chat, but due to time, we'll go ahead and go on to our last part with Rachel presenting her research, practicing her research presentation that she'll be presenting at SASGOG next month. And so, but if you have any questions for DaShaunda, put them in the chat and she'll address them while Rachel's presenting. So Rachel, I'll hand it over to you to finish us off.
Thank you. And thank you, Dr. Taylor. That was a great presentation. Let me just share my screen. Can everybody see this?
Yes.
Okay. All right. Okay, so my study is called Negative Sleep-Related Cognitions in Women in Opioid Use Disorder Treatment. And here you can see the wonderful contributors of this study, as well as our affiliations with VCU School of Medicine, VCU Department of Psychology, VCU Department of Obstetrics and Gynecology, and VCU Institute for Drug and Alcohol Studies. So as an introduction, insomnia is a sleep disturbance that is very common in individuals in treatment for opioid use disorder. And studies have proposed that the mechanism behind this is kind of bidirectional, with substance use disorder leading to sleep problems, and then sleep problems also becoming a risk factor for substance use recurrence in the future. And so because sleep disturbances are a risk factor for occurrence of substance use, addressing insomnia in women in opioid use disorder treatment may be an avenue to improve clinical outcomes. However, insomnia interventions are very understudied in patients receiving medications for opioid use disorders, such as buprenorphine. And most studies so far examining methods to improve sleep in opioid use disorder patients have focused on pharmacological interventions for the most part. And then on another note, in thinking about other possible contributions to insomnia in women in opioid use disorder, studies have also shown that groups in treatment for opioid use disorder have correlates of sleep disturbance that include current psychiatric comorbidities, one of which is anxiety. And so given this background, targeting insomnia through behavioral approaches directed towards negative sleep-related cognitions, similar to behavioral approaches used for anxiety disorders, may present an opportunity to improve outcomes in women in opioid use disorder treatment. And so the primary objective of this study was to report on negative sleep-related cognitions and insomnia severity among a sample of women receiving buprenorphine by the presence of anxiety. And secondarily, this study also aims to assess the correlations between sleep-related cognitions, insomnia, and anxiety severity. So the methods, this study is a secondary analysis of an ongoing cross-sectional survey and electronic medical record abstraction study investigating the relationship between sleep and opioid use disorder recovery, as we all well know, Project SORT. And the outcomes included were the dysfunctional beliefs and attitudes about sleep, or DBAS, which has items that range from 0 to 10 as 16 total questions related to sleep-related cognitions. And that total average score was taken for that measure. And higher scores indicated more negative sleep-related cognitions. The second outcome was insomnia severity index, which is a range from 0 to 28, with higher scores also indicating higher levels of insomnia symptoms. And the main independent variable was generalized anxiety disorder 7, which is a range of 0 to 21, with scores of greater than or equal to 10, indicating clinically significant anxiety. So that's what we're going to call our group with anxiety, or the presence of anxiety. So total DBAS average scores and ISI scores were compared by presence of clinically significant anxiety using t-tests, and associations between the GAD-7, ISI, and DBAS scores were calculated using correlation coefficients. So the results. So there were total included in this study 64 participants who were from the parent study. In terms of some of their demographics, participants were predominantly white, accounting for 59.4% of participants, and predominantly had Medicaid insurance, accounting for 95.3%. Participants' mean time in treatment for opioid use disorder was 670.6 days, with a wide standard deviation of 498 days. Their mean total daily buprenorphine dose was 24 milligrams, and their median duration on buprenorphine was 1.8 years, although the range was from 21 days to 5 years. And then in terms of how many participants included actually had clinically significant anxiety symptoms by the GAD-7, 26 participants, or 41%, had screen positive GAD-7, so scores greater than or equal to 10. And 38 participants did not have scores greater than or equal to 10, or 59% of participants. And so data analysis showed that participants who had clinically significant anxiety reported significantly higher insomnia severity levels. So the group with anxiety had a total mean of 19.56 on their ISI score with a standard deviation of 6.23, while the group with no anxiety had a mean score of 10.47 with a standard deviation of 7.33. The significance had a p-value of less than 0.001. Additionally, participants with anxiety also reported significantly higher total negative sleep-related cognitions. So the group with anxiety had a total average DBA score of 6.62 with a standard deviation of 1.92, and the group with no anxiety had a total DBA mean score of 4.27 with a standard deviation of 2.23, and then p-value, again, less than 0.001. Furthermore, negative sleep-related cognitions were positively correlated with severity of both anxiety and insomnia, and both of these were significant with a p-value of less than 0.001, and insomnia was also positively correlated with anxiety as well. And so when examining the top endorsed negative sleep-related cognitions on the DBAS, the following cognitions had the highest individual item scores. And I won't read all of them, but just for example, like I need 8 hours of sleep to feel refreshed and function well during the day. Or when I do not get a proper amount of sleep on a given night, I need to catch up the next day by napping or on the next night by sleeping longer. I can't ever predict whether I will have a good or poor night's sleep. And so this is kind of just to give you an idea of what kinds of cognitions the participants were recording the most. And so the big kind of take-home message from all of this is that in the sample of women receiving buprenorphine for opioid use disorder, insomnia and anxiety symptoms were very prevalent, and patients with anxiety endorsed more severe insomnia symptoms and negative sleep-related cognitions than patients without anxiety. So these cognitions related to kind of categories of consequences of lack of sleep, expectations surrounding sleep, worry and feelings of helplessness about sleep, and medication-related beliefs surrounding sleep. And so the implications of this are that insomnia therapies for women incorporated into opioid use disorder treatment should consider dually focusing on both anxiety and negative sleep-related cognitions. And so intervention studies such as with cognitive behavioral therapy for insomnia or CBTI are probably needed in this growing opioid use disorder patient population. And the findings kind of emphasize that there are opportunities to tailor future trials to opioid use disorder patients, their unique needs, and by gender. And this is our funding here.
Great job, Rachel. That was great.
Thank you.
Your findings are very interesting, especially thinking about, and they're very clinically applicable, thinking about interventions like the behavioral ones that you loop into the presentation, which is very good. I've seen your poster before and have given you feedback already. So does anyone have any questions or any points of clarification or any suggestions for Rachel as she is going to be presenting her poster at SASGOG next month? I guess not. I think you did an excellent job personally. So the only suggestion I would give is just to maybe shorten it a little bit, because I think there's going to be like 50 something posters in this one room, and people are going to want to go to multiple of them. And so that's the only suggestion I would give, is just to shorten it. And then people will look and then point at your poster as you're talking. And then if people want to hear more background or more of your methods or more of your results, they'll ask you. So that's the only suggestion I would give, just from a logistical standpoint of how poster presentations generally work. Usually try to do like 2 points for each section, like 2 points background, 2 points methods, point out your main result and then your take home message, point at your poster while you do it. And then people will ask you questions, and then you can go into more detail, like what you just did.
Got it. Thank you, Dr. Martin.
Yeah, so that was excellent. Awesome. Well, thank you, everyone. Sorry we went over a few minutes, but we appreciate you coming to our lab meeting. And thank you again, Dr. Taylor, and thank you again, Rachel, for your presentations tonight. And we will let y'all know when our next lab meeting is, and we appreciate you coming. I hope everyone has a great evening. Thank you.